We are discussing ACS, acute coronary syndrome. It includes unstable angina and MI. The patient present with emergency with severe central chest pain with radiation to left arm, jaw, and there is profuse sweating, blood pressure dropped, pulse high, and ECG shows ST segment elevation in leads 2-3 AVF. Then characteristic features worsening unstable angina, crescendo angina, severe ischemic chest pain lasting greater than 30 minutes and radiating to throat, arms, epigastrium, and back. Greater than 30 minutes last occur in Stemi. Sweating, pallor, troponin may be elevated. MI region with ECG areas. The ECG features we are discussing here: ST segment elevation and ST depression. ST segment elevation if occur in V1 to V4, then it is anteroseptal wall MI, and if it occur in if it occur in V3 to V4, it is anterior. 1 AVL and V4 V6 is anterolateral. 2-3 AVF is inferior, and ST depression in V1 to V4 is posterior. Unstable angina. In unstable angina, there is no myocardial injury, but is MI, there is myocardial injury present. Now we are discussing some features of unstable angina, Nstemi and Stemi. Coronary thrombosis in unstable is subtotal and subtotal and Stemi total. History: angina that is new onset, and or angina occurring at rest and lasting less than 30 minutes. Same is that for Stemi, but in same is that for Nstemi. And then for Stemi, angina occurring at rest with greater than 30 minutes. ECG features: in unstable angina and Nstemi, there is same ST depression, T wave inversion, ST depression, and in Stemi there is ST elevation. Cardiac enzyme is negative in unstable angina, positive in Nstemi and Stemi. The difference between unstable angina and Nstemi is of cardiac enzymes. Then criteria for acute MI is new ischemic ECG changes, pathological Q waves, loss of viable myocardium, and coronary thrombus. Then there is clinical features of MI include chest pain, crushing, radiation to neck, jaw, arms, back, and pain does not respond to nitroglycerin or rest. There may be epigastric pain. Then there is Killip classification of severity of heart failure: class 1, 2, 3, 4. Class 1 no heart failure, class 2 crackles with audible halfway up to chest, class 3 crackles heard in all lung fields, class 4 cardiogenic shock. What are the clinical features of acute coronary syndrome? Symptoms is chest pain, nausea, vomiting, breathlessness, collapse, syncope, anxiety, and fear of impending death. Sign: we divide into sympathetic and vagal and impaired myocardial function. Sympathetic include pallor, sweating, tachycardia; vagal activation, vomiting, bradycardia. Impaired MI include hypertension, oliguria, cold peripheries, narrow pulse pressure, raised jugular venous pulse pressure, third heart sound, quiet first heart sound, and diffuse apical impulse, lung palpitations. Now we'll move to investigation. Same we discussed in angina. We will do ECG exercise, ambulatory, chest X-ray, cardiac enzymes, and echo, and then we go with CT, MRI, and we go with cardiac catheterization and coronary angiography. And here we ECG findings. Here we discussing it. If there is if we see changes in HM elevation, VT inversion. See, if we see changes, see elevation in 2-3 AVF, it will lead to inferior wall MI, and artery involved is RCA, right coronary artery. Then we go with interior wall MI, anteroseptal and anterolateral. Interior wall MI includes V3, V4, and artery LAD. Then anteroseptal V1 to V4, artery includes LAD. Then anterolateral V4 to V6, 1 AVL, LAD or circumflex. Posterior wall MI, the artery is posterior descending, and leads includes V1 to V4 with ST depression and tall upright T wave and tall R waves. Cardio biomarkers, then we will go with cardio biomarkers includes troponin and CKMB. In unstable angina, no rise in troponin. Troponin TNI is a gold standard, began to rise in 3 to 6 hours, peak 36 hours, and remain elevated for 2 weeks. CKMB increases 4 to 8 hours, peak in 24 hours, and return to normal within 48 to 72 hours. CKMB is helpful in detecting reinfarction because as troponin began to remain elevated for 2 weeks, we does not if second attack occurs, then we then if second attack occurs, we cannot we cannot judge or predict from troponin levels. If second attack occurs on fourth or fifth day, then CKMB will again be elevated, which gives us a clue of reinfarction. Radiography, echo, coronary angiography with PCI, cabbage, other investigations, CBC, leukocytosis, ESR, CRP, lipid, TFTs, and blood glucose, RFTs. Then we move toward management. Management is immediate management and long-term management, and then there is different management for Nstemi. We are discussing management of Stemi. General management includes monab therapy, morphine, oxygen, nitrates. Antithrombotic includes aspirin, clopidogrel, ticagrelor, tirofiban, abciximab, and beta blockers. And then the specific include two: PCI, percutaneous coronary intervention, and thrombolytic. We are discussing PCI. PCS is a treatment of choice within 12 hours, and it is given with glycoprotein 2b3 receptor antagonist, which include tirofiban and abciximab. There is no mortality benefit in Nstemi and not performed in unstable angina. We are of PCI not performed in unstable angina. Then there is thrombolytic therapy, which includes agents streptokinase, alteplase. It is given within first 12 hours, especially within first 2 hours, with low molecular weight heparin, fondaparinux. And then there is long-term management include lifestyle changes, diet, smoking, exercise, dehydration. We have to deal with. Then there is secondary prevention and devices. Secondary prevention drug therapy include antiplatelet therapy, include aspirin, clopidogrel, beta blockers, ACE, ARBs, inhibitors, statins, control diabetes, hypertension, mineralocorticoid, and receptor antagonist, spironolactone. Then there is lipid-lowering statins. Devices is cardiac defibrillator. The treatment of Nstemi include low molecular weight heparin, fondaparinux, nitrate, coronary angiography, revascularization. Symptomatic treatment includes anti-anginal, antiemetic, diuretics, beta blockers, and ACE inhibitors. Then move towards the contraindication to thrombolytic therapy: active bleeding, subarachnoid intracerebral hemorrhage, hypertension, recent surgery, trauma, active peptic ulcer, pregnancy. Then we are discussing complication of acute MI, which includes arrhythmias, recurrent angina, acute heart failure, pericarditis, Dressler syndrome. Dressler syndrome include fever, pericarditis, pleurisy, then papillary muscle rupture, ventricular septal rupture, ventricular rupture, embolism, ventricular remodeling, ventricular aneurysm. Ventricular remodeling is a thinning and stretching of the infarct segment, and drugs which prevent remodeling: beta blockers, ACE inhibitors, and mineralocorticoid receptor antagonist, which is spironolactone.